is Ms. Ajari, and today we're going to cover the concept of digestion. So understand that the digestive process begins in the mouth, so any alterations along the GI tract will affect how well that patient can digest the nutrients in their food. We will also want to consider the motility of the GI tract. Understand that that is regulated by the autonomic nervous system. So start thinking about any kind of chronic neurologic conditions that your patient could have that could interfere with GI motility, or any medications that the patient may be on that will interfere with motility. When we talk about absorption, we want to understand that absorption mostly occurs in the intestines. So any problems that are in the intestinal mucosa will also interfere with how well the patient is able to digest their food. Some clinical manifestations that we can see in a patient with problems in digestion include nausea, vomiting, anorexia, heartburn, and acid indigestion. And we can see these symptoms in diseases like hepatitis, pyloric stenosis, and pancreatitis. When we're assessing the patient with problems with digestion, we want to look at the underlying cause. So if the patient's presenting to us with an issue like vomiting, we want to know what caused the vomiting. We need to find out, and we would do that by further observing the patient or by interviewing the patient and asking, have they traveled out of the country recently? What did they eat? Have they been eating? If they did eat, was it a meal that was high in fat content or high in alcohol? We also want to do a physical exam on the patient with a focused assessment on the GI system, and that would include bowel sounds, looking at the abdomen, inspecting, auscultating, percussing, and palpating. We also want to look at how old the patient is. So we know that infants can present with issues with pyloric stenosis. Let's think about toddlers who may have issues with their digestion because they're holding in bowel movements because they're potty training. We can have issues with pregnant women and heartburn. And think about that lifespan all the way up to our older adults who can start having issues with any problems in their GI tract, or maybe just not wanting to eat, and anorexia. So you really want to also consider the lifespan of your patient. Diagnostics. It's important for you to know the diagnostics that are appropriate for digestion, but also know the nursing considerations. So what I mean by that is, does the patient need a consent? Is it an invasive procedure? What do I need to assess before the procedure, and what do I need to assess after? So for example, if we look at this list, an endoscopy is an invasive procedure. The patient's gag reflex can be affected, so we would want to make sure that we're assessing gag reflex after that procedure. Amylase and lipase are blood tests, and we will see those elevated in issues with the pancreas. In collaborative therapies, we want to think of all the things that we can use to help the patient's issue with digestion. So there are medications that we can give. There are things like lifestyle changes or modifications that we can discuss with the patient. There's complementary medicine. And then we want to go over their diet, what they should be eating, what they should be avoiding. And then we also, if the patient needs a boost to their nutrition, we can consider enteral or total parenteral nutrition. So we're going to do a compare and contrast of enteral nutrition and parenteral nutrition. And this seems to be kind of a concept that students have some difficulty with. So we're going to discuss why we would choose enteral nutrition over parenteral nutrition. When we're saying enteral nutrition, think that enteral nutrition needs to enter the GI tract, right? So if we're going to give enteral nutrition, it needs to enter the GI tract. That means that the GI tract needs to be intact. right? Otherwise, we would have to bypass it, because if we give the patient nutrition through the GI tract and that GI tract is not working, the patient will not be able to digest that food. So if we are giving enteral nutrition, we can give that for issues like a patient who has a poor gag reflex, difficulty swallowing, if they've had oral or neck surgery and can't obviously use their mouth or above the neck, trauma, anorexia, or serious illness. And the way we give that is through a nasogastric tube, so a tube that enters through the nares to the back of the throat and down into the esophagus and into the stomach. We can also use a nasoduodenal tube, which will just go a little bit further, right, into the duodenum. A gastrostomy tube, which is a tube that's inserted surgically into the stomach. It can also be inserted into the jejunum, and we would give that feeding through either gravity, or, which is just attaching a tube to that NG tube or G tube and letting an enteral feeding, like an Ensure kind of feeding, into the tube, or we can give it continuously through a tube feeding pump. What we want to, some nursing considerations for a patient that's getting an NG tube is to make sure that we're confirming placement. So when an NG tube is placed, okay, before we can use it, that first time it's placed, we must do an x-ray to confirm placement, okay, because we want to make sure that it's not in the patient's lungs, that it is where it's supposed to be in the stomach. So we need to do a abdominal x-ray to confirm placement of that NG tube. After that, obviously, we're not going to do an x-ray every time we need to feed that patient through that tube. So after that, we would confirm placement by verifying the pH of their gastric content. If the patient's GI tract is not intact, we cannot enter it, we will use parenteral nutrition. And that's given through either an IV or a central line. Okay. If it is an IV, it is called PPN, okay, peripheral parenteral nutrition. And if it's through a central line, it's called TPN, total parenteral nutrition. We give a hypertonic solution which contains carbohydrates, amino acids, fluids and electrolytes, vitamins, minerals, and we can choose to give them lipids or not, and that will be based on what the doctor orders. The patient does not have a functioning GI tract, remember, okay? So these patients would be patients with pancreatitis, with ulcerative colitis, with a small bowel obstruction. It must be given, TPN must be given through a central line. It must be given on an IV pump, and we must have a dedicated line, which means we can't mix any other infusions in with TPN. If the line is getting TPN, it can only get TPN. Some nursing considerations for a patient that's getting TPN: high risk of infection, glucose intolerance because that TPN bag has so much sugar in it, fluid overload, dehydration, electrolyte imbalance, and pneumothorax is a risk factor once the central line is being placed. So it's not really a consideration for TPN per se. It's more because the patient is getting a central line, and we know that pneumothorax is a risk of central line. So the exemplar that we're going to cover today is acute pancreatitis, but we're going to go over general pancreatitis and then compare and contrast acute and chronic. So what is the function of the pancreas? Pancreas secretes enzymes that helps to digest proteins, starches, and fatty acids. Once the pancreas becomes inflamed, those enzymes get activated early, and they actually start to digest the pancreas itself. It attacks the pancreas and surrounding tissue, and that process is called autodigestion. Some diagnostics specific to pancreatitis include serum amylase and lipase, ultrasound or an endoscopic ultrasound, CAT scan with contrast, MRCP or ERCP, percutaneous fine needle aspirate. Again, anytime we have diagnostics, you always want to think of what are the nursing considerations related to that diagnostic test. So let's talk a little bit about acute pancreatitis. This is an inflammation of the pancreas. It is reversible. The pancreas starts to self-destruct, right? We mentioned autodigestion and that pancreatic enzymes are secreted early and they start to attack the pancreas. It's most common in middle-aged adults. Gallstones and alcoholism are the majority of the cause of acute pancreatitis. Mortality and symptoms depend on the severity, the type, the age, and general health of the patient. Other factors like trauma, surgery, third semester pregnancy, elevated calcium levels, high levels of lipids in the blood can also contribute to acute pancreatitis. So what do we see in the patient with acute pancreatitis? We see a sudden and abrupt onset of severe epigastric, mid-epigastric, and abdominal pain. It often radiates to the back and can be relieved when the patient sits forward. It often occurs after the patient has eaten a very high-fat meal or has had a lot of alcohol. The patient will have nausea, vomiting, abdominal distension, hypoactive bowel sounds. They can be tachycardic and hypotensive, an elevated temp, cold, clammy skin. Within 24 hours, we can see a mild jaundice. We can see Turner sign and Cullen sign, which will, you will see that picture up on your module. And we will monitor the patient for hypovolemia because we know as the patient loses volume, they're more at risk to experience hypovolemic shock. We also know that there's an association between acute pancreatitis and ARDS. So how do we treat it? First, we keep the patient NPO, nothing by mouth. We have to replace fluids for them, so we need to give them lots of IV hydration. A big issue for them is pain, so we need to control their pain. And we may or may not give them antibiotics. There's some literature that says, yes, we still use it, and some literature that says, no, we may not. So you may see differences based on where you're practicing. So now let's compare this to chronic pancreatitis. This is a chronic condition, a chronic inflammation. It's a gradual destruction of the pancreas. So the pancreas decreases its function. Remember we said acute was abrupt onset. This is more of a chronic condition. It is not reversible. So unlike acute pancreatitis, which we said was reversible, chronic pancreatitis is irreversible. Alcoholism is the primary risk factor in the United States. So we always want to get that kind of history from our patients. What do we see in the patient? Similar to acute pancreatitis, it's epigastric pain. They do have abdominal pain. It does radiate to the back. That pain can last from days to weeks. As it progresses, the intervals between those episodes of pain become shorter. The patient can experience anorexia, nausea, vomiting, weight loss, flatulence, constipation, and steatorrhea, which is a fatty, frothy, foul-smelling stool. So what's our goal for the patient? First, they're in pain, so we want to promote comfort. We want to control that nausea and vomiting, and we want to give them IV fluids. We're going to be observing the patient, assessing the patient. We want to interview the patient, right? Ask them when this vomiting began, what did they eat before, did they eat before, those kind of questions. And then we want to do our focused GI assessment. Some nursing diagnoses that would be appropriate for these patients. In the patient with acute pancreatitis, certainly acute pain, a fluid volume deficit, nausea, imbalanced nutrition, less than body requirements. When you're planning for this patient, you want to think the patient will. Okay, so if I have goals for that patient, I want to say by the end of the shift, the patient will, or by the time of discharge, the patient will. Okay. Implementation: manage pain, control nausea and vomiting, insert and maintain an NG tube when indicated, and then good oral hygiene. When would we insert an NG tube? If the patient's vomiting continually, if we've medicated the patient for nausea and vomiting and they're not responding, they're still vomiting, then that would be an indication to insert an NG tube. We also want to do patient teaching. So if the patient is drinking or smoking, we want them to stop. We want to go over appropriate diet, any medications and supplements that they may be on. In terms of medications and nutrition, opioid analgesics would be our go-to. They may or may not receive a prophylactic antibiotic. Since the pancreas is no longer functioning, it won't be able to secrete the enzymes that it normally does, so they'll need pancreatic enzyme supplements. They may be on H2 receptor blockers, on PPIs. They will be NPO in acute episodes. They will have an NG tube to suction. They will be on IV fluids at a pretty good rate, like maybe 200 an hour, 250 an hour, seen up to 500 mLs per hour. For long term, they may need some TPN because they are not able to get their nutrition right through their GI tract. We will resume oral feedings once the amylase is normal, once they have present bowel sounds, and once their pain is resolved. They will be on a low-fat diet and obviously not drinking. If the cause of the pancreatitis is due to gallstones, then the patient may have surgery to remove those gallstones. So takeaways, what do you need to get from this? Any problems along the GI tract will interfere with the process of digestion. Consider the age and developmental stages of your client. Know the normals and abnormals of a GI assessment. Know the nursing considerations for all your diagnostics. Compare and contrast acute and chronic pancreatitis, including clinical manifestations and treatments. And understand the implications for enteral and parenteral nutrition.